An emergency plan keeps people safe, but a service continuity plan keeps the care moving. And in my experience working across aged care governance and clinical management in Australia, I can tell you that most organizations understand the first part far better than they understand the second part. Now, let me explain the difference because it matters enormously. Most aged care, healthcare, and disability service organizations have an emergency management plan. That plan exists to manage immediate, let's say, safety threats, evacuation, fire response, lockdowns, acute medical emergencies, natural disasters. These are critical, non-negotiable, and rightly required under the aged care quality standards, specifically under Standard 8 of organizational governance and under work health and safety legislation across Australian jurisdiction. But here is the question that continuity planning exists to answer. What happened after the emergency? Who covers the shift when 40% of your staff cannot attend due to community outbreak or adverse, say, weather event? What happens to your resident if oxygen deliveries are disrupted for 24 hours? What is your process if your primary medication supplier cannot fulfill an order? Or what do your, say, nurses do if your clinical information system fails during medication round and paper based backup processes have not been practiced or tested? What is your escalation pathway if your facility manager and care manager are both unavailable simultaneously? These are not hypothetical scenarios. These are situations that have occurred in Australian aged care and healthcare settings. And the organizations that navigated them safely were the ones that had invested in genuine service continuity planning before the disruption occurred. You know, so service continuity planning is the operational framework that sits beyond the emergency response. Its purpose is to maintain safe, sustainable care delivery during and after period of significant disruption. In Australian aged care, this means your organization clearly identified minimum safe staffing thresholds below which care cannot be safely delivered. It means you have mapped your critical supplier dependencies and have documented alternative arrangement. It means your escalation pathways are known, practiced, and current. It means your clinical team understands how to prioritize care delivery when resources are constrained, and that prioritization is documented rather than left to individual judgment under pressure. It also means your communication systems have been tested, like family, staff, regulators, and external providers all need clear information during a disruption. The absence of a communication plan during a continuity event is itself a governance failure. From a regulatory perspective, the Aged Care Quality Safety and Commission expects provider to demonstrate organizational resilience as part of their governance obligation. The Australian Commission and Safety and Quality in Healthcare similarly recognizes business continuity as a component of safe clinical governance within the national safety and quality health services standards. Continuity planning is not optional best practice. It is an expectation embedded in the governance frameworks that regulate Australian healthcare services. What I have observed in organizations that do this well is a consistent pattern. Their leaders do not wait for a crisis to test their system. They run tabletop exercise. They audit their suppliers' agreements annually. They review their minimum staffing models in light of acuity changes. They train their clinical leads to continuity decision making, not just emergency response. And when disruption does occur, it, and it will occur. They are not building the plan in the middle of the crisis. They are actually executing one that is already exists. Here is the clinical governance principle I return to consequently. A well written emergency plan protects lives during crisis. A strong service continuity plan protects the quality and safety of the care in the hours and days that follow. Both are necessity. Neither is sufficient without the other. In healthcare leadership, preparedness is not measured by whether the alarm worked on the day the emergency. It is measured by whether safe, dignified, person centered care continued when your systems were under sustained pressure. That is the standard your residents, participants, and patients deserve. And it is the standard that strong clinical governance demands. I am Ed from Clinical Insights with Ed. If this gave you something to take back to your organization, share it with your leadership team. Subscribe for more, and I will see you next in the next video. Bye for now.